Good afternoon, everyone. My name is Tan Tan, and I'm an editorial writer with the Seattle Times here in Seattle. I apologize ahead of time. We are starting a few minutes late because we had some technical issues. But today, our board is hosting a Google Plus on-air chat on the issue of mental health in Washington State. And this is based on a series of editorials and columns that we've been publishing throughout the week. You'll hear more about that during this roughly half-hour conversation. But I'm going to introduce the people who are in this chat right now, and I'm just going to ask our speakers to raise your hand when I mention your name. I'd like to welcome Cinda Johnson, who's the co-author of Perfect Chaos, A Daughter's Struggle to Survive Bipolar and a Mother's Journey to Save Her. We have David Stone, Chief Executive of Sound Mental Health. Scott Bond, Chief Executive of the Washington State Hospital Association. Jonathan Martin, my colleague here, and the lead editorial writer on these editorials on mental health. And again, my name is Tan Tan. So I'm going to start by going to Jonathan. And Jonathan, can you tell us can you tell people what inspired our board to take on this issue of mental health and the main points that you're hoping people will take from our writing on this?
Yeah, thanks, Tan, and thanks everybody for joining us. You know, I see mental health as an issue that touches just about everybody, and yet is both poorly misunderstood, and it's also it's a core function of government that government just doesn't do very well. So we were hoping to shine a light, particularly through the lens of the Affordable Care Act, which just really kicked in fully in January. The Affordable Care Act has a great promise to improve mental health care, because with broader coverage and a mental health parity being fully enacted. So I applied for a fellowship with the Rosalind Carter Mental Health Journalism Center. The Carters have a long history of advocating for a better mental health system. And as part of that fellowship, I spent several months running around trying to figure out what are some of the prescriptions for a better mental health system.
And what are the, well, you wrote these amazing editorials, which we can't read them on the air here, but let's go on. I'm going to have each person in this chat just kind of talk about the perspective that you bring to the table and maybe what you're hoping people can take away from the series of editorials that Jonathan wrote as well. Cinda, and also a reminder to our audience, anybody who's watching out there, we do have a Q&A function, so after we get through more or less these opening statements from our guests, you're welcome to ask questions, and I'll be moderating and looking for those and asking our speakers as those questions come in. So once again, we have the Q&A function up and running as well. Cinda?
Thank you, and thank you, Tan and Jonathan, for inviting me to be part of this, and my colleagues on this discussion. Every morning, I've opened up the Seattle Times in the last week. I've cheered. I am so excited with the work that you guys are doing, and I think the reason is that mental illness is always kind of in the background. So it's really, really wonderful to have the emphasis on this. I come from two perspectives. I'm a professor that teaches about this, particularly with children and adolescents, and then I had the opportunity to experience it up close and personal as a family member. As my daughter became ill with bipolar disorder, she journaled through the whole thing, and we wrote this book, and I've learned way more than I ever knew as a professional. So that's my background, and I look forward to hearing from everyone else on this panel as well. Thanks.
Thank you. David Stone?
As a mental health professional, I've been in the field for far too long, 40 years actually, in community mental health. But I also, like like folks from many families, we have had several of our folks over the years experience mental health issues or chemical dependency issues. So I have a passion for it actually, and I'm extremely thankful to the Seattle Times. I echo Cinda's thoughts for its emphasis on the various aspects of mental health and mental illness. It's just an incredible contribution to our community.
Thank you. Scott Bond?
There we go. Sorry about that. Got the mute button. Like the two other panelists, I do want to thank the Times as well for this coverage. It is a very timely topic. the State Hospital Association, Washington State Hospital Association membership are all of the non-federal hospitals in the state of Washington. So the perspective I'm going to bring is on that of the community hospital and academic centers in our state. We supported and advocated for the ruling by the Supreme Court on boarding. That is that involuntary treatment, that act doesn't authorize boarding of a patient in an emergency room to avoid overcrowding in another certified evaluation and treatment facility. We supported that, we advocated for that, and we're frankly delighted with the decision. Still, near term, this ruling presents a big challenge. As we work with others seeking solutions, we're very concerned about the near-term potential impact on patients, families, and caregivers. So the decision is directionally correct and full of complexity, which maybe we'll get into, but for a person requiring care in the near term, it's an issue of great need and importance, and the stakes are very high. So I welcome being part of this today.
Thank you. Jonathan, can you talk to us about what you found is working, with the Affordable Care Act? What has that done for mental health here in Washington State? What's working, what's not working? Some of your main observations.
Well, the first observation is that if you look at the data from the number of people that are accessing the mental health system, it looks like a hockey stick on its side. After January, the number of intakes from the state outpatient clinics just really went through the roof. And I'm hoping that David can talk a little bit about what that's looked like for him. So the idea being, if you have more people covered and there is going to be care available, that is going to be a tremendous preventative resource. I was disappointed in some other aspects of the Affordable Care Act. I mentioned the mental health parity aspect. This is the part of the law that basically says disorders from the neck above and the neck below are going to be covered equally by insurers. There's a long history of insurers not equally covering mental illness like the physical illness, and found a sort of disappointing lack of enforcement, particularly by the insurance commissioner, Mike Kreidler's office. So I think those are sort of two of the takeaways. There's a number of, I think, issues about the availability of care, particularly the number of providers that are available in the to help people. And I'm curious, maybe if Scott can address some of the issues with hospitals getting enough, psychiatrists are in chronic shortage. And lastly, in sort of addressing sort of Cinda's point about seeing the system from the inside out, I think there is still just a tremendous amount of confusion. The mental health system is not an easy. It's not really a system. It's sort of that implies that there's some kind of functionality. I think there's a great number of people working very hard and diligently and earnestly, but it is not easy for families, particularly those in crisis, to figure out where to go, where to get the best help, and how to best access what's there.
Thanks, Jonathan. Let's tackle this one at a time. You mentioned David. David, let's go to you and talk about, from the perspective as the leader over at Sound Mental Health, how has the Affordable Care Act, how are you seeing the effects of that new law take effect on the ground?
Well, as we expected, we've definitely had an upturn in the number of folks knocking on our door for services. We expected that, and we're very pleased to see it. I'm a little surprised that it hasn't started declining after the first few months, but I'm pleased that it hasn't, because it means that people are actually becoming aware that for many of them, for the first time, they actually have the insurance capability to receive the services that they've often needed for quite a long time. So we've definitely seen an upturn in the number of folks coming in our doors. And although that's primarily at this point people who are newly eligible for Medicaid, we're also starting to see folks who have signed on to one of the federally subsidized insurance plans as well. So it's definitely one of the positives of the Accountable Care Act.
Can you talk about the mental health parity issue as well?
Sure. Mental health parity is an issue that throughout almost my entire career, it was a concept that provider organizations always worked hard to secure in Congress, and obviously it finally came to fruition just within the last few years. In concept, it's a wonderful idea. We should have always had it. In practice, it's obviously pretty complicated, because it's one thing to be able to say, well, we should cover mental health issues equally as any other medical condition, but there are all kinds of medical conditions, and there are all kinds of mental health issues, and so it's a much harder law to implement. The other thing I would say is that mental health parity, the way that it's structured in this country, is it only really is a factor for people who are commercially insured, who have insurance through commercial plans generally. People who lack that, it's much less of a benefit potentially on the ground. And so I think we just have to recognize that. It's wonderful for those who have commercial insurance. It's less of a factor for those without.
Thank you. And Jonathan brought up this issue of access as well. And Scott, can you talk to us about that? About how do we train more? How do we build our cadre, or the number of mental health professionals that we have in this state?
Well, I think that again, it's a topic that's been touched on in some of your reporting. But near term, this issue is very pressing, and so some of the solutions that involve training more professionals are going to take a lot of time. And so one of the things that we're championing as an association with others is much stronger support for telemedicine, the ability in telepsychiatry to take this limited skilled clinical resource and be able to project it into more locations. Research has shown that it's effective, and frankly it's part of the reality that we're going to deal with for some time. There just is not enough talent given the need that is present today.
And does anybody else want to weigh in on the issue of how to increase the number of providers, maybe what the message is to the legislature or to Congress?
There was a loan repayment program, particularly intended to incentivize mental health, healthcare providers across the spectrum, particularly lower served areas. That program really got whacked back. It was not a ton of money, but I think that it makes a difference in providing as much incentive as you can. The numbers, particularly around psychiatrists, which are the easiest to measure, show that the urban areas in Washington, around the country, there's tremendous more resources for psychiatrists in the urban cores than the rural areas. I think that's why Scott talked about telemedicine might be particularly useful in rural areas. But the legislature really should take a look at that loan repayment program as well.
I would absolutely second that. When I was in graduate school studying psychology eons ago, the only way I was able to stay in graduate school was there was federal funding. There was a stipend available that would repay the loan that I received if I worked in a community mental health setting, which is, of course, how I got into this field in the first place. If we're serious about the Accountable Care Act being successful and meeting all of its major objectives, we've got to dramatically increase the number of professionals in this field, psychiatrists for sure, but also many other workers, social workers, psychologists, etc. If we don't do that, if we don't find a way to do that, what we will have accomplished is creating a very strong increase in demand for services and lots of waiting lists, or just an inability to meet those demands.
Thank you. Go ahead,
Yeah, I'm speaking from family, I think, here. And I just want to say my daughter was actually invited to be part of this, but she's on her way flying back from Brown University, where she started her graduate program today. And so I've been thinking a lot about how was it that she was able to become well enough and stable enough to pursue a graduate degree. And so that's another part of this conversation, I'm sure. But on the issue of finding more doctors and more psychiatrists, we've had the opportunity to present to what's called the baby docs at both Harborview and at the University of Washington in their first year or two of medical school. And so many of them say they've never heard a story from someone who actually has a mental illness. And it's I think that's something that we need to push into the medical field, is the real stories, because we had so many people come up afterwards that said, I never thought about going into psychiatry, but hearing you talk, it was like, oh, that sounds like something that would be very interesting to me. And then we presented to nurses, and they all ended it by getting more training about identifying depression, because they may see someone who comes in, they're always thinking about domestic violence and checking with women, but they're not necessarily talking to people about the symptoms of depression. So I think we can broaden the people in the medical field who have access to families and help us think about mental illnesses more than is happening now, if that makes sense.
Mm-hmm.
That does. And Jonathan, I think you had you wrote a blog post after the editorial was released talking about trying to bust the stigma of mental health, and it touches everyone in some way, whether it's somebody that we know or people are feeling it, personally. But do you want to talk a little more about that? I mean, for folks who are watching, what's the message to the general public here, because we haven't yet really, mental health, kind of has this stigma still associated with it. What's the message you think to everyone out there?
Well, first, I want to give enthusiastic endorsement to Cinda and Linnea's book. It's really a tremendous insight. And Linnea is such a wonderful writer. To be able to write about bipolar disorder from the inside is just a real service. So, a big endorsement. One of the things that struck me in talking to as many, I've covered mental health care for a year, about a decade, off and on, and it always strikes me that the stories we hear in the news are pretty much all after the fact, and it's after the illness has gotten untreated. And there's so many people that are living these great, full lives in recovery. And I think that the idea of mental health recovery might seem foreign to people that are not experiencing it, but it's no more foreign than being in recovery from cancer or from diabetes or a chronic illness. It's something that can be managed and treated, and occasionally you're going to have your illness flare back up, and you deal with it. So I think that the stigma aspect of this really has it's fundamental in the way that the mental health system is siloed off from the physical healthcare system. I mean, Medicare was the primary funder for a lot of folks, and Medicare has basically an entire separate way of treating, billing for and treating mental health. And I think that's really sort of rooted in the fear of misunderstanding and fear of what it really is. So I think the recovery stories, such as Linnea and Cinda wrote, are really at the core of changing the public perception.
And maybe it's time to give my 3 little things about what I think about recovery. I've been thinking about this a lot, and I think, in the simplest way possible, in the short amount of time we have, that it's not just recovery, but thriving and being able to live a life that you want. And it's an ongoing process, but I think 3 things have to be in place, and one is family, and that may mean that you don't have family, but then community, or something like Sound Mental Health is family for many people. But there has to be someone, because when you're trying to figure out this system and your mind is sick and your thinking is disordered, it's impossible sometimes to get through it. Even with a PhD and knowing the system, I had so many problems. So you have to have somebody, a navigator, a support system, something. And then the access to the resources, it's so difficult to find those. There has to be more resources, but a way to know they're out there and a way to understand how to get to them. And parity, yeah, parity's great, but you know, they don't pay for a nutritionist for someone with an eating disorder. It just doesn't make sense. So having access and information. And then third one has really struck me with my journey with Linnea, and that is advocacy and empowerment. Seeing this as a civil rights movement, and I've seen Linnea's recovery and her ability to achieve what she wants by having her voice out there and saying, I live with bipolar disorder, but I need to have the equal access. She's found other people. She's been part of other organizations. And I think that's been the third leg of her recovery. And I would wish that for everyone. And that is family or support, access to resources and have a way to get to them, and being part of a bigger group so that you know that people live well with a mental illness. If I were queen.
Jonathan, if I may add to that, there's a very, very important element to this, in that our inpatient treatment capacity is severely undersized and limited, and in part, it's limited because there are not options to transition people out of inpatient care to other settings. And what Cinda was speaking to are the kind of services that need to be in place. Our two largest centers, one in Spokane, Providence Sacred Heart Medical Center, and Harborview, both have frequently commented that they have a number of patients that they see in an acute way multiple times over many months. In fact, Harborview has noted that if they could find the means to more smoothly transition their patients out, they could care for another 200 patients a year. But what's happening is, one, there's not a place to go to for long-term care, but also the lack of resources that need to be present in support structures in a community to intervene and avoid that acute episodic stage again, which then calls upon the most expensive part of the system to respond, and it uses up resources that could really be used much more efficiently.
Well, you know, the boarding ruling by the Supreme Court earlier this month, it struck me a little as it came down, and the immediate response to it is that there's that Rahm Emanuel quote, "You never let a good disaster go to waste." And I don't mean to be flip about it, but the legislature's attention is focused on this right now. We're going through these endorsement interviews with all the legislators, and we keep asking about this across the ideological and fiscal spectrum, and everybody agrees, yes, this is a core function of government that we've neglected and we can no longer do so. But I would be curious, I mean, they're talking about, I think, $30 million now for the rest of the year, maybe $100 million for the next biennium. And it really strikes me that most people are talking about just in terms of beds. And I would be curious to hear from the three of you, what if there is going to be more resources pumped into this because of the ruling, what that should look like.
Well, I don't mind starting with that one. That's near and dear to our heart. On the community mental health side, for a very long time, we have advocated, or we've been very clear and on the record with legislators and policymakers that we could take more folks out of the state hospitals, out of the local hospitals, and serve them with appropriate levels of funding. And it's not just funding for outpatient mental health services or chemical dependency services. It's also some funding for the other key support services that either we offer or that we partner with others to offer. Housing is a big one. You know, it's as Scott and anyone who knows inpatient services is well aware of, that you know, nobody wants to discharge somebody from an inpatient psychiatric unit onto the street. And so part of what providers like Sound Mental Health do is to ensure that when somebody comes out of an inpatient unit, they have a place to stay, as well as an appointment with a psychiatrist or a social worker or whomever. And then another key service is all of us know who are working in the working area, is it really helps to have a job if you're capable of holding one. And so for those, and there's a lot of them, for those folks who are able to get stabilized psychiatrically or medically, if they can get some help either developing job skills, or if they've already have them, to landing and holding a job, that's another key support that agencies like ours offer and are necessary to help keep the inpatient usage at a reasonable level.
I want to second David's comment on supportive housing, and specifically look to Medicaid to expand supportive housing for patients who otherwise are known within the system, so to speak, as cycling through the system. I mean, do it on a case-finding basis to get started, because in many cases, these are individuals that are suffering from their illness in such a way that they're not succeeding economically, which means they're not succeeding in their ability to provide a safe and comfortable place to live. Those things are foundational to us addressing this problem. I worry, Jonathan, that we need more beds. We need more treatment facilities. We need more beds opened at Western and Eastern State. In all these cases, however, if there's a focus on beds and not on, so where does the patient transition to following that inpatient service, or the point we raised earlier, I think we may have more success finding physical beds than we're going to find a complement of clinical staff that's able to staff them. And so to draw attention, yes, beds is going to be very important. We need more of them. This is very real. This is a complex problem for all of us sitting here. It's very real for the patient next week that finds himself in a circumstance where the system does not have capacity and they are not detained. The family issues, everything that's associated with that, we got to have beds. But boy, if we don't round this out and look at the other elements, I'm fearful we'll just once again address just one aspect of it.
And I would like to add to that early intervention. I mean, so much time and effort and money is spent on crisis and treatment and then trying to figure out what to do next. But if we could have emphasis with our young adults and our high school students and our families with early intervention, recognizing the symptoms and being able to get help before it's a crisis, that would be also, I think, very helpful, because you all work with the people who didn't get that.
That's a good point.
Yeah, there's some great legislation the last several years on expanding suicide prevention training out to, particularly into schools. It's really an encouraging trend. It's a lot of terrific advocacy work done on that. So, one of the things that struck me in covering mental health care for a long time is that, David and Scott here are talking in very similar language, but there's historically been like a lot of tension within the system about how much prevention the outpatient side and the inpatient side have not always worked the best together, or there's different advocacy elements within the mental health community. I'm wondering if this boarding issue is, you see this as a potential to have some of the similar sort of political friction within the advocacy community, or if this is because of the opportunities presented, it's a different moment.
Well, additional resources would make a huge difference. Jonathan, you talked about some of the ideas that are on the table, and frankly, the system is just terribly underfunded, and that leads to some of the tension that is present. The inpatient side is frustrated in its inability to transition out. There are many on the outpatient side that have spoke to me saying, "Boy, more money on the in the institutional side that's a very expensive place, as I noted earlier, to spend the money. So we don't want to do too much of that." I mean, I think what's different though is this circumstance, this ruling. While it's not the whole, I clearly think it's put the conversation in a different place and we do have to take advantage of the opportunity that's before us.
Yeah, I mean, Washington State's, I think, been proud for a long, long time as being at the very bottom or very close to the bottom of all the states in terms of the number of hospital beds for people with mental illness. You know, that's obviously, to some extent, a good goal to have, because we don't want to unnecessarily hospitalize people. But on the other hand, you know, I think it also should be cause for us to step back and take a look at, you know, is this a balanced system that we're operating and that we're funding, or is it kind of we gone a little bit too far in one direction? And I think that's part of the conversation that's probably going on now at multiple levels. We, as an outpatient, primarily an outpatient provider, obviously we believe in outpatient services. We believe in residential services in the community. But we also know that there is a need at times for some people who are in crisis who need more than outpatient services can provide, and we have to have a balance of those various services. We have to be wise about it.
Okay, so we're going to wind down the conversation. We've gone a little over 30 minutes now, and you guys are all doing, this is really, really amazing insight. But as we consider our audience out there, the folks who are watching, let's assume that lawmakers are watching this now, or they may see this in the replay that we're going to be posting on the website after this. How are you going to measure success, you know, or progress? You know, in particular, I'd like each of you to recap and just talk about specific reforms or bills that you would like to see the legislature take action on in a few months when they meet in Olympia. Can we start? Actually, you know what? I'll just leave it open. Whoever wants to start.
Well, I'll start. And we have presented to the governor some thoughts of short-term options. I mean, they clearly start with, we have to appropriate funds for beds, appropriate dollars, including non-Medicaid dollars, state-only dollars, to the regional support networks, which are the bodies that really handle and distribute the funds to create more capacity. Many are working hard to try to create more beds, but it's the need near term is much greater than the supply. So job one is the point that was made earlier. There just has to be more funds put in it. In our world, we think that the state should waive certain regulatory processes. One is called the Certificate of Need, where the Department of Health, which license certified evaluation and treatment centers and freestanding hospitals, could create a different kind of waiver. And I won't go into the details, but it could help expedite things. I think that we've got to look at what payment levels are for some of the new centers that come up. There are some specific codes that could be, Washington administrative codes, that could be changed. Finally, I think we just have to find a way to get more short-term beds in place at Eastern and Western State, and then work with them longer term to find a way to have more long-term care beds in those two settings.
Thank you.
I would, if I could only advocate for one kind of law that I'd like to see us, that I think we really need in this state, it would be in the area of what often is called outpatient commitment. I know that some other states have such laws. They can be controversial, but on the other hand, they also can be very successful. And what I'm referring to is a law which allows, under certain circumstances, for an individual who typically has gone into an inpatient psychiatric treatment, has been released for whatever reasons, and clearly needs, unfortunately, needs kind of enforced follow-up care as an outpatient, often because these folks have shown either some dangerous behavior to themselves or to someone else, or sometimes just because they continue to be really unstable psychiatrically, and they're not able to make decisions that are in their own best interest, let alone others. And so I really believe strongly that in this state we need a law that provides, in those relatively rare circumstances, care for a described or defined period of time to ensure that those folks get the kind of outpatient follow-up that they clearly need. It is not humane for any of us to allow a system to prevail in which people clearly cannot care for themselves, and in the name of saying, well, that's their right. You know, yeah, it's their right to be sick, it's their right to be suicidal, but it is not in anyone's best interest to allow that kind of a system to prevail.
You asked for measurements, I think, and since you guys have all kind of addressed everything I think you've said has been very thought-provoking, I'll go back to something really simple, and that is if we were to do a survey of our citizens in Washington State and ask them how hard or how easy it was to find mental health treatment, what would they say? And I think that because we've been out there sharing our story, we hear such horrendous stories from people that, you know, they can't, I mean, from middle-class people who cannot find a psychiatrist to see a family member for 6 months, to a family that has no resources, has nowhere to go, to a family that doesn't speak English. We just hear so many stories. And I have them call, you know, NAMI, Sound Mental Health, NAVOS. You know, I'm sending them out there. I have them call our own psychiatrist's office. But it's hard, and you've got to make so many phone calls and so many connections. So I would love a survey to come back, a random survey that said, I knew where to go, and I got a response. And when I couldn't understand it, I've had a navigator that helped me through the system. That would be a measurement to me to the legislation that where they're trying to push into additional funding.
And related to that, or as an add-on to that, Cinda, you know, I'd love for us to see, it wouldn't have to be a lot of money, but a pot of money put into a period of time to really publicize what services are out there and how to access them.
Absolutely.
We're not talking mega millions of dollars here. We could do a very sound campaign statewide that would accomplish those kinds of objectives for a reasonable amount of money.
And by doing so, we would also provide opportunities for faces to come out and for people to feel comfortable to say, you know, I'm a CEO and I have schizophrenia. I'm a nurse and I have bipolar. Live with bipolar. And therefore, we can all have those people helping find and do a campaign, exactly, which then builds advocacy so that it's not just 3 voices pushing the legislator, but it's the whole community.
Right.
These are all great recommendations. I just posted, by the way, to follow up on David's point on the chat. I posted a New York Times story about an assisted outpatient therapy program. That's a review by Duke University. It found it to be it really is working. You know, and talk about measurements. It's a great question, Ton. You know, one of the core elements, I think, that when people think about the mental health system not working, they look at what's happening in prisons and jails. And I think if we're going to measure this, I think that we would have a dramatic reduction in the percentage of people with serious mental illness in prisons and jails. You know, right now, the Department of Corrections estimates there's maybe 25% of inmates have a serious mental illness. These are major diagnoses. Jails, I think, are much worse, and you have both of them really struggle to have folks who are that ill in those environments. So that's a broader goal. I'm not sure maybe it's not quite specific enough, but I think that's really got to be on the table.
Thank you all for your thoughts. And just a note to our audience, I apologize, the Q&A function, it looks like it wasn't working throughout this entire chat, but if you go to the upper left-hand corner of your screen, you should be able to take a look at some of the notes in a chat that I think Sharon, our associate editor, who's been on the back end helping us out, she's added a link. Jonathan had a link. I've linked to our editorial package. So for those of you who are interested in reading more about mental health, the issues here in Washington State that have been covered by the Seattle Times editorial board. I encourage you to take a look at the links that we provide in the chat section of this Google Plus feature. And I'd like to really thank all of our panelists today for joining us and for providing such thought-provoking insight into a very important issue. And hopefully folks out there will help us to spread the message, keep this conversation going. So once again, I want to thank Cinda Johnson, co-author of Perfect Chaos, A Daughter's Struggle to Survive Bipolar and a Mother's Journey to Save Her. I'd like to thank David Stone, Chief Executive of Sound Mental Health, Scott Bond, Chief Executive of the Washington State Hospital Association, and my colleague Jonathan Martin for really taking the lead and helping our board to put a really important issue out there. For those of you who are interested in watching this chat later on or spreading the message, go to Seattle Times Opinions blog, go to seattletimes.com and go to the opinion section and check it out there. Once again, my name is Ton Tan, and thank you everyone for participating in today's chat.
Thank you.
Thank you.
Thank you.